This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you. Okay, this is going to be Chapter 9, Pulmonary Emergencies, Part 2, and other medications. We're going to talk about Decadron, diphenhydramine, furosemide, hydrocortisone, and medrol. So, steroids have a multi-use in the body. They'll allow the body to resensitize itself to catecholamines. They have essentially an all-access pass inside the cell and adjust the way that the cell is communicating through its DNA. So, new proteins can be formulated and the entire cellular environment is changed. So very simply, a steroid can alter cellular environments, and the two major reasons that we utilize steroids are, one, to decrease inflammation. It stops the cellular mediated response whenever we have an immune system response, and two, to resensitize the body to catecholamines. Now, an example of that would be you've had somebody that's used their inhaler all day long, and they've used it 10, 15 times, but time that they call EMS. So whenever you get there, your first albuterol treatment doesn't do as well as you would hope. Put the medrol on board, and about 10 minutes later, that second one will probably work. You've told the cells to please pay attention to the next albuterol that I'm going to put on board. Antihistamine. When we get a degranulation of a mast cell, and that's this thing here, mast cell, we release histamine. And what histamine does is it hits the receptors, and those receptors will cause vasodilation in the vessels. So the vessels go from this to this. Now that causes a leaky system whenever it occurs systemically. The systemic version of a histamine release, we generally give people, and this would be for anaphylaxis, we give people things like antihistamines, we give them alpha-1 adrenergic agonist, which would be like epinephrine, and that's so that we can get a little bit of containment, so that it takes vessels that are this big and takes them back the other way to where they're more manageable and we can maintain cardiac output. Diuretics. We see these with respiratory emergencies when people have CHF. The diuretics that we're going to talk about are the ones, now all diuretics are listed on this slide, but the diuretics that we're going to actually talk about are these guys right here, and more specifically furosemide and Bumex. So both of these essentially keep sodium in the tubule, so that the point that water has an opportunity to come back in and becomes permeable to water again. Very simply, it will make more urine. In the overall scheme of things, the more water that we keep inside the tubule, the more water is in our urine. So, Decadron, general knowledge. Generic on this is dexamethasone, and the trade name is Decadron. Mechanism of action, long-acting synthetic adrenocorticoid with intense anti-inflammatory or glucocorticoid activity and minimal mineralocorticoid activity. As an anti-inflammatory agent, it prevents accumulation of inflammatory cells at the site of infection, inhibits phagocytosis and lysosomal enzyme release, and synthesis of selected chemical mediators of inflammation, reduces capillary dilation and permeability. Utilized to manage the inflammatory responses seen in anaphylaxis, and also used for cerebral edema, but that actual action is controversial. Adult dose is 0.75 to 9 milligrams daily. Pediatric dose is 0.5 to 2 milligrams per kilogram per day. Contraindications: systemic fungal infections, hypersensitivity, cerebral malaria. Pharmacokinetics: onset in 8 to 24 hours, so this is kind of a long-term effect on this. Metabolized in the liver and excreted in the urine. Hydrocortisone, also general knowledge. Generic on this is hydrocortisone, and the trade name is Solu. Mechanism of action: short-acting synthetic steroid with both glucocorticoid and mineralocorticoid properties that affect nearly all systems of the body. By inhibiting the formation, storage, and release of histamine from mast cells, it reduces its effects of an allergic response. It also increases the body's response to circulating catecholamine. So we're going to see this utilized as well, Solu, in catecholamine-resistant septicemias in pediatrics whenever we get to pediatrics. So this resensitizes their body to adrenaline and epinephrine and norepinephrine. Adult dose 15 to 240 milligrams every 12 hours. Pediatric dose, if you're under 12 years old, 2.5 to 10 milligrams per kilogram per day. If you're over 12 years old, it's the same as the adult. Contraindications: any serious infections, because we are going to immunosuppress the patient, and hypersensitivity to the actual medication. Pharmacokinetic: onset varies and the half-life is 1 to 2 hours. Metabolized in the liver and eliminated in the kidneys. Diphenhydramine. Generic on this is diphenhydramine, and the trade name diphenhydramine hydrochloride or Benadryl. Mechanism of action: competes with free histamine for binding at histamine receptor sites. This antagonizes the effects of histamine on histamine receptor sites, leading to the reduction of negative symptoms brought about by histamine receptor site binding. Very simply, this decreases the amount of degranulated histamine that's in the system. Adult dose in this is a narcotic adjunct, and what this means is during some of the same receptor sites are utilized, or it potentiates the effects of narcotics, if you will. 12.5 to 25 milligrams. IV in an allergic IV for the narcotic adjunct. In an allergic reaction, 25 to 50 milligrams IV IM. Pediatric dosing: 1 milligram per kilogram IV IM or IO. Contraindications: no absolute contraindications when used in an emergency setting. Pharmacokinetics: onset is immediate if given IV, 20 to 30 minutes IM. Duration is going to be 3 to 6 hours. Metabolized in the liver and excreted in the urine. Solumedrol: this is going to be a primary care drug. Generic on this is going to be methylprednisolone, and the trade name is going to be Solumedrol. Mechanism of action: intermediate acting synthetic adrenal corticosteroid with similar glucocorticoid activity but considerably fewer sodium and water retention effects than hydrocortisone. Its pharmacologic actions are vast and complex, and medicine have a wide range of uses. We use this primarily as an anti-inflammatory in pulmonary emergencies. Adult dose is 125 to 250 milligrams IV or IM. Pediatric dose 1 to 2 milligrams per kilogram IV or IM. Contraindications: no major contraindications in the management of acute anaphylaxis. We also use it for anaphylaxis to decrease the cellular mediated response. Pharmacokinetics: peak effects 4 to 8 days IM. Duration 1 to 5 weeks IM. Half-life 3.5 hours. Metabolized in the liver. HPA suppression in 18 to 36 hours. Neuromuscular blocking agents. We're going to talk about Sux, Rox, Vec, Pancuronium, Ketamine, and Nimbex. So neuromuscular blocking agents essentially do what they say. They block the neuromuscular junction. So what we see here, this right here, is there's only one depolarizing neuromuscular blocking agent, and all the rest of them compete in this area here. So let me give you the Barney version of this. This is a nerve and then a muscle membrane. So what a depolarizing paralytic does is it causes a depolarization on the end motor plate that the body cannot respond from for about a good 10 minutes, and that's the half-life of the duration of the drug. So succnicholine, and that's why it also causes fasciculations, because of that erratic firing and that depolarization effect that it has. Non-depolarizing neuromuscular blocking agents essentially work on the postsynaptic side, and on the postsynaptic side, they essentially block the receptors from even being utilized. So they will compete with the receptors in this area for the half-life of the drug. Examples of these would be like Vex, Pavilon is in there, Rocuronium. So all of those medications that we talk about that are non-depolarizing neuromuscular blocking agents work like this. The depolarizing neuromuscular blocking agents depolarize the end motor plate and may cause fasciculations. There's also tons of contraindications for succnicholine. NMDA receptors. Now, the NMDA receptors is another receptor found in the actual synapses area. So if we block this receptor, we essentially get decreased in level of consciousness. Now, ketamine works on the NMDA receptor, and very simply, this would decrease the amount or cause dissociative anesthesia, and it's listed right here. By blocking this, it makes it not function so much, so it doesn't really work on those positive electrons that are coming in to generate an action potential, so it causes a dissociative anesthesia. Neuromuscular blocking agents. In an emergency situation, used on patients that are still responsive yet unable to maintain their airway, drug overdose, seizure, trauma. Neuromuscular blocking agents cause muscle relaxation and facilitate intratracheal intubation. However, they have no effect on the consciousness. The patient is still awake. They are just essentially locked inside of a body they cannot move. Classified as two different categories, which is depolarizing and non-depolarizing agents. Succnicholine or nectane is our only depolarizing paralytic that we have, and it causes a depolarization wave. This is why it gives you fasciculations. Pavilon, Vecuronium, Hydrocortisone, Rocuronium are all non-depolarizing agents. The other side of this is an induction agent. An induction agent gives sedative and hypnotic effects on the patient. Used in conjunction with neuromuscular agents, classic anesthetic is a barbiturate, thiopental sodium. In an emergency medicine, it is diazepam, Valium, or midazolam. Both are rapidly acting and have significant amnesic properties. Short-acting induction agents like ketamine and etomidate are also frequently used. Ketamine does not affect breathing and primarily used in children. Etomidate is a fast-acting, non-benzodiazepine sedative and has hypnotic properties, and this is used pretty much in EMS. Also used in the hospitals as well. You'll see hospitals use it for sedation and for induction of an intubation. Now, induction agents are one-shot medications that do not require a whole rapid sequence, if you will. Rapid sequence, that terminology is primarily used whenever we talk about paralytics proper. Induction methods. We have two versions. Rapid sequence induction, which is hyperventilation of the patient combined with medications to intubate the patient. Rapid administration of fentanyl, midazolam, lidocaine, atropine, and Sux to allow facilitation of an intubation, and that would be the terminology rapid sequence induction, or rapid sequence intubation. Pharmacology Assisted intubations are usually one medication, similar to the rapid sequence, but with no use of paralytics. These are going to depress the LOC enough to where you can facilitate an intubation. Advantages are that paralytics are not used, and the reversal of some of the respiratory depressive effects of some of the medications can be reversed with Narcan. So, first drug, succnicholine, primary care drug. Generic on this is going to be succnicholine, and the trade name is going to be a nectine or succostrin. My apologies, succostrin. Mechanism of action, synthetic ultra-short-acting depolarizing neuromuscular blocking agent with high affinity for acetylcholine receptor sites. Its initial transient contractions and fasciculations are followed by a sustained flaccid skeletal muscle. Paralysis produced by a state of accommodation that develops in adjunct excitable muscle membranes. It may increase vagal tone initially, particularly in children, and with high doses, and subsequently produces mild sympathetic stimulation. Following IV injection, muscle paralysis begins with eyelids, jaw, then progresses to the limbs, abdomen, and diaphragm. There is no effect on the level of consciousness, so they're essentially locked inside the body. You're going to have to load this medication with something that has amnesic effects. Adult dose in this is 1 to 1.5 milligrams per kilogram. IV or IM. Pediatric dosing is 1 to 2 milligrams per kilogram IV IM, and I realize that that's a larger dose, and that is correct. Pediatrics require more. Contraindications, if they have any hypersensitivity to this drug whatsoever, a family history of malignant hyperthermia, any kind of penetrating eye injury, any kind of glaucoma or narrow angle glaucoma, hyperkalemic states. That includes and possibly maybe even burns. Be aware that this is going to paralyze your patient once applied. Pharmacokinetics onsets in 0.5 to 1 or half to 1 minute IV, 2 to 3 minutes IM, durations in 2 to 3 minutes IV, 10 to 30 minutes IM, crosses the placenta in small amounts, metabolized in the plasma by pseudocholinesterases, and excreted in the urine. This is a depolarizing paralytic. Rocuronium, primary care paralytic as well. Generic Rocuronium bromide. Trade name is Zimuron. Mechanism of action, non-depolarizing neuromuscular blocking agent that competes with acetylcholine molecules and binds to muscarinic acetylcholine receptors at the postsynapsis membrane of the motor end plate. It blocks the actions of acetylcholine and prevents activation of the muscle contraction process. It can also act on nicotinic presynaptic acetylcholine receptors, which inhibits the release of acetylcholine. Adult dose is 0.6 to 1.2 milligrams per kilogram for the first dose, and a maintenance of 0.1 to 0.2 milligrams per kilogram every 20 to 30 minutes. Or this can be done via IV as a continuous drip, 0.01 to 0.12 milligrams per kilogram per minute IV. Pediatric doses are not recommended in children, and contraindication of this drug is going to be hypersensitivity. Pharmacokinetics, onset 1 to 2 minutes, duration 31 to 67 minutes, and that would be dose dependent. Upper end doses you may get a little more than that, and this is going to be excreted in the urine. Rocuronium, primary care as well. Generic is going to be Rocuronium, and the trade name is going to be Norcuron. Mechanism of action, intermediate acting non-depolarizing skeletal muscle relaxant, structurally similar to pancuronium. It demonstrates negligible histamine release and therefore has minimal effect on the cardiovascular system. Unique metabolic and excretion pathway like atracurium, Rocuronium also inhibits neuromuscular transmission by competitively binding with acetylcholine to motor end plate receptors. It is given only after induction of general anesthesia. Adult dose 0.08 to 0.1 milligrams per kilogram IV. Pediatric dose 1 year or older is the same as the adult dose, weight dependent. Contraindications, hypersensitivity, impaired acid-base or fluid electrolyte balance. Pharmacokinetics, onset 3 to 5 minutes, duration 20 to 35 minutes, eliminated in the urine and feces. Pavilon. Generic on this is going to be pancuronium bromide. The trade name is going to be Pavilon. Mechanism of action, synthetic derivative of curare used to facilitate intratracheal intubation. Competes with acetylcholine at its receptors in the postsynaptic membrane. Results in paralysis of muscle fibers served by the neuromuscular junction. It is reported to be 5 times as potent as curare, but produces little or no histamine release or ganglionic blocking, and thus does not cause bronchospasms or hypotension. It does not cause initial depolarization wave, as does the succnicholine, so we don't get fasciculations, which look like little twitches. Adult dose 0.04 to 0.1 milligrams per kilogram IV. Pediatric dose is 0.02 milligrams per kilogram IV in neonates. Over 1 month is the same as an adult. Contraindications would be hypersensitivity to the drug. Pharmacokinetics, onset 1 to 2 minutes, duration 60 minutes, excretion in the urine. Ketamine, primary care. Generic on this is going to be ketamine, and the trade is going to be Ketalar. Mechanism of action, produces dissociative anesthesia, blocks the NMDA receptor. Overdose may lead to panic attacks and aggressive behavior, rarely seizures, increased ICP and cardiac arrest. Very similar in chemical makeup to PCP, but shorter acting and less toxic. Ketamine does not react with the GABA receptors. So this causes dissociative anesthesia, essentially unplugs your brain from the rest of it. Adult dose on this is going to be 1 to 4.5 milligrams per kilogram, slow IV once. Pediatric dose 1 to 2 milligrams per kilogram. Contraindications, hypersensitivity, and this is relatively controversial, head trauma, intracranial mass, hemorrhage, hypertension, angina, stroke, underlying psychiatric disorder. Because we do not want to unplug your head if you already have psychosis. Pharmacokinetics, onset 30 seconds IV, duration is going to be 5 to 10 minutes, dissociative state, greater than 20 minutes, metabolized in the liver and is excreted in the urine. Nimbex. Rocuronium mesylate is a generic, and the trade name is Nimbex, which is a lot easier to pronounce. Mechanism of action, also non-depolarizing skeletal muscle relaxant, binds to the nicotinic acetylcholine receptors at the motor end plate and blocks access to the receptors. In the process of binding, the receptor is actually activated, causing a process known as depolarization. Since it is not degraded in the neuromuscular junction, the depolarization membrane remains depolarized and unresponsive to other impulses, causing muscle paralysis. Adult dose is 0.15 to 0.2 milligrams per kilogram. Pediatric dose, same as the adult dose. Contraindications on this is going to be malignant hyperthermia. Pharmacokinetics, onset 1.5 to 2 minutes, and duration is going to be 55 to 65 minutes. Half-life of 22 to 30 minutes. Metabolizes via Hoffman's elimination, interdependent of the liver, and excreted via Hoffman's elimination as well. Rapid sequence inhibition. Now, what we have here is a general overview, and I'll want you all to go through it. In Carden Farm slide test, you'll have to perform a rapid sequence inhibition. Pretty simple. Very simply, we prepare and assemble our equipment. We've got to be sure that all of our equipment's there. Pre-oxygenate the patient and administer pre-medication, which in this case I put on here midazolam. Now, these are options on both sides. So both of these sides here are options. Option 1, if the patient has intracranial pressure, then consider a loading dose of lidocaine. If their heart rate is low or there might be increase in vagal tone, a loading dose of atropine might be appropriate as well. Or if their heart rate's around 80 or 70, maybe a half of a dose of atropine might be effective. Please remember to push the atropine quickly, because if you push it slow, it'll have untoward effects. This over here, let's go to the other side, is also an option. Consider a defasciculating dose of the neuromuscular blocking agent. An example of this, I use Vex. We use 1/10 of the dose as a defasciculating dose. Now what that does is before we administer the Sux and depolarize the patient, we give them 1/10 of the dose of the neuromuscular blocking agent. Now what that does is that blocks the receptor site so that it won't respond. Fasciculations can cause hyperkalemic events in people that are near the border, so we should always consider this. It also is politically correct. If family members are present in the room, they may get kind of alarmed whenever your patient looks like they're having mild seizures, which they aren't actually, they're just fasciculating. Apply posterior cricoid pressure, have suction readily available, and administer the paralytic agent, Succnicholine, 1 to 1.5 milligrams per kilogram. Intubate the patient, confirm ET tube placement, release the cricoid pressure, and maintain paralysis and sedation. Sedation would be occurring because of this, so half-life of the midazolam needs to be considered. And then this is old school version, so we can consider Pavilon or Rocuronium at 0.1 milligrams per kilogram to keep the patient down. Rocuronium would last about 30 minutes, and the Pavilon would last about 60. Pharmacology Assisted intubation. Now, this version of intubation is with one drug, so this is a quick overview of this. Talk about this more in lab. We will prepare and assemble the equipment, pre-oxygenate the patient, and have the suction ready and administer the medication. Now, each one of these medications are a one-shot version of facilitated intubation. Don't require Versed or anything like that unless you're using Versed to facilitate this. So the etomidate induction dose is 0.3, ketamine induction dose 1 to 2, propofol slower onset 2 milligrams per kilogram IV push. This generally is only done by an anesthesiologist or a physician. That's why we didn't put it in the actual drug cards. This is Dipervan or propofol. Midazolam, prolonged duration of action, usually underdosed, 0.3 milligrams per kilogram. So for a 70 kilogram person, they would require 20 milligrams of Versed. Intubate the patient, confirm placement, release cricoid pressure, and maintain their sedation. Conclusion. Having to fight for each breath can be very frightening for your patient. Rapid assessment and proper recognition of signs and symptoms by the EMS professional can be life-saving. The most important drug used during a respiratory emergency is oxygen. Some conditions may require additional drug options such as bronchodilator, anti-asthmatics, or anti-inflammatory drugs. It is important to know each drug classification included in your protocols. References for this chapter were taken from Beck Pharmacology for EMS Providers, Delmar Learning, Brian Bledsoe's Pre-Hospital Emergency Pharmacology 7th edition, and various places throughout the internet. If you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, smithr@imsa.net, or 405-219-7613. Thank you.